Welcome to the Pharmacology Education Series. In the next 15 minutes, we're going to take a practical look at Xultophy 100/3.6, a fixed ratio combination of insulin degludec and liraglutide used to treat adults with type 2 diabetes. A quick but important reminder. This presentation is for educational purposes only. It is not medical, pharmacy, or nursing advice, and it is not a substitute for clinical judgment. Always verify dosing and safety information against the current FDA-approved package insert before any clinical decision. Here is the roadmap. We'll start with drug identity and what's inside the pen, then walk through mechanism, pharmacokinetics, and pharmacodynamics. We'll cover the indication and how to dose. We'll dig into the boxed warning and contraindications, then warnings, adverse reactions, and drug interactions. Finally, we'll review special populations and the key clinical evidence. Let's start with identity. The brand name is Xultophy 100/3.6. The generic name is insulin degludec plus liraglutide. It's a fixed ratio combination of a long-acting basal insulin and a GLP-1 receptor agonist. It's given subcutaneously in the thigh, upper arm, or abdomen. The FDA initially approved it in 2016. Now look at what's actually in the pen. Each 3 milliliter pre-filled single patient use pen contains 300 units of insulin degludec and 10.8 milligrams of liraglutide. That's where the 100/3.6 in the name comes from. 100 units per milliliter of insulin degludec and 3.6 milligrams per milliliter of liraglutide. Here is the critical ratio to remember. Every dosage unit delivers 1 unit of insulin degludec plus 0.036 milligrams of liraglutide. The pen dials in 1 unit increments, and the dose range is 10 to 50 units once daily. Why combine these two molecules? Because they target different parts of the glucose control problem. Insulin degludec is a long-acting basal insulin analog. It stimulates glucose uptake in muscle and fat, inhibits hepatic glucose production, and forms a subcutaneous depot that releases slowly. Half-life, about 25 hours, steady state in 2 to 3 days. Liraglutide is a GLP-1 receptor agonist, about 97% homologous to native GLP-1. It stimulates insulin release in a glucose-dependent way, decreases glucagon, and slows gastric emptying. Half-life, about 13 hours. Together, they reduce both fasting and postprandial glucose with a single once-daily injection. Xultophy is indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. Notice the word adjunct. This is not first-line therapy, and it's not approved in children. It's used together with diet and exercise, and frequently alongside oral anti-diabetic agents. There are also several important limitations of use. Xultophy is not recommended together with any other liraglutide or GLP-1 receptor agonist-containing product. So no Victoza, no Ozempic, no Trulicity, no Wegovy, and no Saxenda on top of Xultophy. It is not for diabetic ketoacidosis. It has not been studied with prandial, that is mealtime, insulin. It is not recommended in patients with severe gastroparesis, and it is not for type 1 diabetes. Dosing depends on prior therapy. If the patient is naive to basal insulin and to GLP-1 receptor agonists, start at 10 units once daily. 10 units degludec plus 0.36 milligrams liraglutide. If the patient is already on a basal insulin or a GLP-1 receptor agonist, discontinue that first, then start Xultophy at 16 units once daily. Maximum daily dose, 50 units, which is 1.8 milligrams of liraglutide. Do not exceed it. Titrate by 2 units once or twice weekly, every 3 to 4 days, based on self-monitored fasting plasma glucose versus target. Give it subcutaneously in the thigh, upper arm, or abdomen, and rotate sites. Once daily at the same time, with or without food. Missed dose. Take the next scheduled dose. Do not double up. If more than 3 days have passed, restart at 10 units to limit GI side effects. Never IV, never in a pump, never mix, never split. Xultophy comes as a clear, colorless solution in a 3 milliliter pre-filled single patient use pen that dials in 1 unit increments. 5 pens per carton. Inactive ingredients include glycerol, phenol, zinc, and water for injection. For storage. Before first use, refrigerate at 36 to 46 degrees Fahrenheit until the labeled expiration. After first use, the pen can stay at room temperature, 59 to 86 Fahrenheit, or back in the fridge for up to 21 days, then discard. Even if product remains, never freeze. Discard if it has been frozen. Keep away from heat and light. Always remove the needle after each injection. Now the most important safety information, the boxed warning. Liraglutide causes dose and treatment duration-dependent thyroid C-cell tumors at clinically relevant exposures in both male and female rats and mice. It is unknown whether Xultophy will cause these tumors, including medullary thyroid carcinoma, or MTC, in humans. Counsel patients about that risk and tell them to watch for a neck mass, trouble swallowing, shortness of breath, or persistent hoarseness. Because of that risk, Xultophy is contraindicated in any patient with a personal or family history of medullary thyroid carcinoma, or in anyone with multiple endocrine neoplasia syndrome type 2, MEN2. There are 2 other contraindications worth knowing. Do not give it during an episode of hypoglycemia, and do not give it to anyone with a serious hypersensitivity to insulin degludec, liraglutide, or any of the excipients. There are 13 warnings and precautions in the label. Going quickly through them: 1. Thyroid C-cell tumors, the boxed warning. 2. Acute pancreatitis, stop if suspected. 3. Never share a pen, because of blood-borne pathogen risk. 4. Any change in insulin regimen can cause hyper or hypoglycemia. 5. Medication errors and overdose. 2 drugs in 1 pen, always check the label, never exceed 50 units per day. 6. Hypoglycemia is the most common adverse reaction and can be life-threatening. 7. Acute kidney injury from volume depletion after nausea, vomiting, or diarrhea. 8. Severe GI reactions, not recommended in severe gastroparesis. 9. Hypersensitivity reactions, including anaphylaxis and angioedema, discontinue immediately. 10. Acute gallbladder disease, cholelithiasis, and cholecystitis. 11. Hypokalemia. Insulin shifts potassium intracellularly. 12. Heart failure with thiazolidinediones, the TZDs. 13. Pulmonary aspiration during general anesthesia or deep sedation. Patients must inform any anesthesia team. In the clinical trial program of 1,881 patients, the most common adverse reactions, those occurring in at least 5% of patients, were nasopharyngitis at 10%, headache at 9%, nausea at 8%, diarrhea at 8%, increased lipase at 7%, and upper respiratory tract infection at 6%. Hypoglycemia is the most common adverse reaction overall, but severe hypoglycemia was uncommon, ranging from 0 to about 0.7% across the trial arms. Gastrointestinal symptoms, nausea, diarrhea, vomiting, constipation, tend to appear early and improve with continued treatment. Expect a mean heart rate increase of 2 to 3 beats per minute from the liraglutide component. Injection site reactions occurred in roughly 2.6% of patients, and patients converting from liraglutide to Xultophy had a mean weight gain of about 2 kilograms. Drug interactions fall into 4 practical buckets. 1. drugs that may increase hypoglycemia risk, other anti-diabetic agents, ACE inhibitors, ARBs, fibrates, fluoxetine, MAO inhibitors, pramlintide, salicylates, octreotide, and sulfonamide antibiotics. May need to reduce the Xultophy dose and check glucose more often. 2. Drugs that may decrease the glucose-lowering effect. Atypical antipsychotics, corticosteroids, diuretics, estrogens, isoniazid, niacin, oral contraceptives, protease inhibitors, sympathomimetics, and thyroid hormones. May need to dose up. 3. Drugs that can go either way, alcohol, beta blockers, clonidine, and lithium. Pentamidine can cause hypoglycemia followed by hyperglycemia. 4. Drugs that blunt the signs of hypoglycemia, beta blockers, clonidine, guanethidine, reserpine. Monitor glucose more frequently. And remember, liraglutide delays gastric emptying, so use caution with oral medications, especially anything with a narrow therapeutic window. In pregnancy, use Xultophy only if the potential benefit justifies the potential risk. Liraglutide caused fetal harm in animal reproduction studies. In lactation, there is no human milk data, and both components were present in lactating rat milk, so weigh benefits and risks. Pediatric use, safety, and effectiveness have not been established. In geriatric patients, 65 and older, there were no overall differences in safety or efficacy, but start conservatively because hypoglycemia can be harder to recognize. For renal impairment, there is limited experience in mild to moderate disease and no data in severe impairment. Individualize the dose and monitor glucose closely. For hepatic impairment, Xultophy itself has not been studied. Use caution and monitor. Importantly, the label does not give a fixed percentage dose reduction for renal or hepatic impairment. The instruction is to individualize, titrate to the patient's response, monitor glucose more frequently, and watch closely for hypoglycemia, GI effects, and changes in kidney function, especially during initiation and dose escalation. Quick PK summary. Insulin degludec has a half-life of about 25 hours and is more than 99% protein-bound. Liraglutide has a half-life of about 13 hours and is more than 98% protein-bound. Both reach steady state in 2 to 3 days. Insulin degludec is metabolized similarly to human insulin with inactive metabolites. Liraglutide is broken down endogenously by general proteolysis. There's no specific organ that drives its elimination. In renal impairment, degludec exposure does not change in a clinically relevant way, and hemodialysis doesn't affect its clearance. Liraglutide AUC is actually about 19 to 35% lower in renal impairment and end-stage renal disease. The explanation is not fully understood. In severe hepatic impairment, liraglutide AUC is about 42% lower. Age, sex, and ethnicity do not require dose adjustments. Exposure does decrease as body weight increases, which is why titration to clinical response matters. If a patient takes too much, expect hypoglycemia and severe GI effects. For mild hypoglycemia, give oral glucose. For severe hypoglycemia with coma or seizure, give IM or subcutaneous glucagon or IV dextrose with continued observation. Correct hypokalemia if present. For liraglutide overdose, expect severe nausea and vomiting and provide supportive care. Consider poison help at 1-800-222-1222. Counseling essentials. Always check the pen label before each injection. Never share the pen. Rotate injection sites. Recognize and treat hypoglycemia and carry fast-acting sugar. Report any neck mass, hoarseness, swallowing trouble, or breathing trouble. Report severe abdominal pain immediately. It could be pancreatitis. Stay hydrated when sick to reduce kidney injury risk. And tell every healthcare provider, especially anesthesia, before any surgery or procedure. In summary, Xultophy 100 over 3.6 is 2 molecules in one once-daily injection. Insulin degludec for basal control, plus liraglutide for GLP-1 effects. It's an adjunct to diet and exercise for adults with type 2 diabetes, not first line. Start at 10 units if naive, 16 units if switching, maximum 50 units per day. Titrate by 2 units once or twice weekly. There is a boxed warning for thyroid C-cell tumors. It is contraindicated in personal or family MTC history or MEN2. Watch for hypoglycemia, pancreatitis, GI effects, kidney injury, gallbladder disease, and aspiration risk under anesthesia. And one more time. This video is for educational purposes only. It is not medical, pharmacy, or nursing advice. Do not rely solely on this content for patient care. Always consult the current FDA-approved package insert and use your own clinical judgment for every patient. Thanks for watching.